We have a few minutes here, so we kind of covered like some of the general things. We have a few cases. They get like a little progressively like more difficult, but they're not too bad. So maybe maybe we can take these cases, like someone can volunteer. If you don't volunteer, then maybe I'll choose you. And you know they get more difficult because I told you. This is like a first year case. This is a first year who wants to take a case. All right, so this is a 59-year-old man. He's got radiating pain down his left leg. He can't walk. So tell me what you see like on these images.
So on our left we have T2, right?
So this one is
T1 and then
okay, great.
T2 on the right is the C-step is right.
Exactly. So just first things first, like where's the abnormality?
So on the anterior superior end plate of L4, there's some abnormal signal, and then
yeah, so there's some abnormal signal here.
Posterior to that, there's some sort of like disc osteophyte complex protruding into the canal.
Yeah, there's something going on right there, right? And so on the T1, you don't really see it that great, but here, like things are clearly, they're narrow. You have something going on. This disc is not like this disc, right? I mean, it's desiccated, so you know there's some degeneration there. The rest of the discs look okay. So what level do you want to call this?
That's L3, L4.
All right, yeah, so that's L3, L4, assuming, like I said, that you're numbering from below with the last normal disc. So here, here's like just some additional images. This is just further lateral. So do you kind of, these are like offset a little bit for some reason. Like this is like, this disc corresponds to this. But what do you see going on here? So you're lateral, you're out sort of at left, you're at the level of the neural frame, and like, what do you see?
So I think again in that area, there's narrowing.
Yeah, so here's like
as clean as the other one.
Yeah, this is like the level above, right? So this is like a nice looking neural frame and like has like a lot of fat around it. Here's your like nerve root. This nerve root is like sitting pretty. It's like very happy. Kind of same thing at the level below. You got like a nice keyhole of fat, nerve root right in the middle. What is going on here? Do you see anything? No. Not really. So you want to call this mild or moderate or severe?
Severe.
All right, severe. I agree with you. And then based on like the appearance here, like what do you want to call this? Do you want to call this what terminology do you want to use?
I would also call that severe.
You can, so you can't really tell about the width of the spinal canal. What do you want to call the pathologic process itself? You want to call it a bulge?
Oh.
You want to call it a protrusion? You want to call it an extrusion? Yeah, I think protrusion is like pretty safe here. I think if you called it an extrusion, that would be okay as well, just because it looks like it's sort of like a little fatter. Here, like you sort of see, so the axials now give you like a little bit more information. You kind of have the disc like coming out, so there's like sort of a broad asymmetric disc bulge. But then out here, like where you were looking at that left neural foramen, and there's like definitely sort of this big kind of protrusion coming out here. If you called it like an extrusion, I'd be okay with that as well, because it's kind of on here, it like looks like it's almost like coming superiorly a little bit. That terminology, use the best that you can, but you sort of identified what's going on. There's a disc there. It's causing severe left neural foraminal narrowing. The canal here like actually doesn't look that bad on the axials, so maybe that's moderate. And those lateral recesses are gone. Like there should be like a little notch for like a nerve root to sit there, and that's going to cause radiculopathy like from the level below. So nice job. They took that person like to the OR. Here it's just sort of pointed out. You got the recess narrowing. Here, like we have these coronals. Like I don't really think they're that useful, so I don't really waste that much time on them. But you can actually kind of see the nerve root. Like I kind of put little dots on there so you can see. The one on the right is like kind of straight. The one on this is the disc, and it's like getting pushed outward by the disc. So you can just kind of see. All right, so good job. Another case. This can be a first-year case too.
I can take it. It's a 36-year-old woman incidentally detected abnormality on MRCP. Okay, so looks like T2 on the left,
Okay, that's right. This is T2.
Middle looks like T1.
Okay, perfect.
And then is that a post-con?
That is a post-contrast. So we didn't talk much about that, but the best way to tell if it's post-contrast is, well, one, there's an enhancing mass here. But the epidural veins, like the epidural venous plexus, is enhancing. And the reason this looks different from the original T1 is like many times the post-contrast have fat saturation, just to, like I said, to exaggerate the differences, because otherwise you can have lesions that enhance the same as fat. So what's going on here?
Like you said, there's an enhancing mass posterior to L2 vertebral body. It looks like it is intramedullary.
So where does the cord usually stop?
So cord usually stops at like L2.
Right. So you're like, are you above the cord? Or are you below?
I see. No. Now that I can see a little, so maybe it looks like it's displacing the cord. I can see that on the T2. So
this is kind of tricky because I think you're getting like some flow artifacts here, and this is like a little tricky. But the conus is somewhere up here. So the only point I was trying to make is that you can't have an intramedullary lesion that's below where the cord stops.
Okay.
And you didn't really know that because I didn't really tell you, so that's not very fair. I do think the nerve roots are displaced like to either side.
Yeah.
But so if it can't be intramedullary, like what do you want to call this?
Intradural.
Yeah, intradural. So it's extramedullary, intradural.
Yeah.
And then so here I'll give you like another image. So this is post contrast as well.
Yeah, so you can see the mass. Is that displacing?
Yeah, you see pretty much only the mass, and like and then like the nerve roots are just smashed to the side. Okay. So you have like yeah, so it's sort of the same thing. You got this mass. It's avidly enhancing. It's an intradural mass. What do you want as your differential diagnosis here?
Schwannoma, meningioma.
All right, perfect. Schwannoma, meningioma, ependymoma can also look like that, but that's not really fair because I didn't tell you that either. You can't really tell them anymore. They took it out. It's a schwannoma. You're done. Like you told them it was a tumor. You told them the differential. If they took it out and they told you that was an ependymoma, you'd be like, all right, great. Like this is your top 3. 97% of the time you're going to be right. That's all you can hope to do. If they take that thing out and it's a MET or a hemangioblastoma or something ridiculous, fine. I mean, you only need to be right 97% of the time. All right. I'm going to allow you to call on a friend to take the second half of this case. You can like set someone up. A volunteer. I think you should let him have it. It's not that bad.
Yeah. Oh no, I'm happy to. Yeah, let's record it.
Oh, he wants to do it. All right, like I like it. Just go straight for the glory. He's like putting that Mercedes logo on his Hyundai, and he's like, I'm gonna get on 280 and just go. All right, so the patient had a resection and came back like with some pain, like.
Yeah. So pain post resection, so T2 on the left, T1 in the middle, and then post com, right?
It is, yeah.
Okay, so pain after surgery. I'm worried about like acute post-surgical complications. Looks like there might be. Gosh.
Yeah, so there's something going on here, right? Like.
Yeah, for sure. But I guess I'm struggling to figure out what might be like a normal post-surgical change. But
I think I think you're on the right track. I think you can have. How would you describe this? Like, what do you think is going on there?
It's like a big fluid collection.
Exactly, it's a big fluid collection, and in the post-surgical setting, like, what can a big post-surgical fluid collection be? Hematoma, abscess, just a seroma, like just like a resolving, liquefying hematoma or whatever. Yeah, and there's a fluid collection there. That sort of gives you your differential. Yeah, I mean, you're sort of like on it right there. You can have a pseudomeningocele, so you can have like a CSF leak from there, and that'll be a pseudomeningocele. So if you could do one other thing, what would you want it to be? You get one other sequence, and you can call in your friend who's offered to help you. You've already had post-contrast. You want one other sequence? You got nothing?
Diffusion.
Of course. In neuro, the answer is always diffusion. Like, just go with diffusion. Like, even if you if you were like asleep, if you were asleep, we had this resident in my program who would like, he was amazing. This was back when like senior residents had to take cases. That guy would sleep and he would hear his name called and immediately wake up and start taking the case like from scratch. Even if it was like a question, he would just like do that. Make that your instinct like in neuro. It's diffusion. All right, so here's your diffusion. Like this is just a regular DWI. Like, what do you think? Is this infected?
Yes.
Do you think it's infected?
No.
So here's this one. All right, I'll help here. Just in the interest of time. This is the conus. So this is the end of the spinal cord. The conus has some restricted diffusion because it has linear fibers in it. If it's not any brighter than the spinal cord itself, it's probably not really reduced diffusion. So there's no reduced diffusion there. So that's like not an infected collection there. I don't expect you guys to get this diagnosis, but it's like one of the most ridiculous cases like I've ever seen. This is like an axial T2 image through there, and then there's like a T1 here. You have like some CSF collection like around there in the surgical bed. Here's the dura here. Yeah, there's a flow jet. Like there's actually like a flow void from CSF is coming out of her so fast into this collection that it's causing a flow void like a vessel. So this patient like had to go back to the OR, and they repaired that. I have a few like other cases. Like it's one. You guys have like a couple. You want to stay for a couple more minutes? You want to stop here? And we'll do a few more. All right. Lung cancer. Pain going down the legs. Volunteer. L4 doesn't look normal, right? This is pre-contrast T1. Pre-contrast T1 is great, right? Things that are dark on T1 are not, almost certainly not normal. It's like you can't really call that a hemangioma when it's like fatty replaced and has like replaced the fat. So there's something going on there, like this guy's like having some pain. I'll give you some more images. Anything else going on here? Use some more. Yeah, there's something going on like with these nerve roots, right? There's like a little something there, a little something there, kind of some clumps there. Something's like not going on. There's a blank slide here. I don't know why that is. So what do you think about those little enhancing nerve roots? Yeah, I mean, this guy has cancer. You know he has a bone met because you saw one. He's got pain. Yeah, you have to like assume that these are mets. And sort of the lesson like of this case is like don't look at that bone met and be like, oh, I'm awesome. Next case. And then like get in your Hyundai and drive off. Like don't do that. Look at the other stuff. I mean, like it's much more significant that this guy has enhancing nerve root mets than that he has a little bone met there. I mean, he has metastatic disease, but like he actually needs like radiotherapy or something to deal with these nerve root mets to help deal with this pain. So definitely like take a look at those things. Here you see like I've just pointed them out. A couple of like nerve root things. You can actually see them on there. Anything else you want to do for this guy? You could say diffusion, but you'd be wrong in this case. Myelogram. That's all soon mean you need to change to ortho. No, you got to image the guy's brain. Like, I mean, you know that like he has drop mets in his spine. You know he's got bone mets. You need to look at his brain. He's got brain mets. Like he's got a bunch of little nodules. Got this little one with hemorrhage over here. More nodules over there. Yeah, so some of these like are leptomeningeal in the brain as well. Like some of those like kind of coating the spine. These are kind of look leptomeningeal as well. Some hemorrhage there. And some of these are probably leptomeningeal as well. I mean, you know there's leptomeningeal mets in the spine. So, all right. Let's go quickly. This is chest. Like, let's skip this completely. All right. So the history was HIV and back pain. All right, next case. Perfect. Yeah, so there's an enhancing mass there. There's destruction of that disc space. You have horrible encroachment like into the spinal canal. You've got prevertebral soft tissue swelling. I like it. Step up to the plate, knock it out of the park. That's discitis osteomyelitis. Oh yeah. So there is a differential for this. You can have lymphoma, Mets, myeloma, and there is like something that will help you differentiate. What would you like? You could get diffusion, and if you got diffusion in this case, so this I don't know why they did diffusion like all the way up here, but it's like pretty typical for our spine imaging. The diffusion is like terrible. But here you see, in contrast to that one before, you've got the spinal cord. You have like a little, you have a certain level of diffusion there. This is considerably reduced compared to the spinal cord. So that's like telling you that this is infection. You kind of already knew, so I think that's like good. This patient got, I don't know, had mitral valve vegetations, and he was like, forget it, I'm out. I'm out. Probably. All right, I think we're probably like running out of time here. I think the cases like get a little more obscure from this point. So we can probably stop here. What's that?
One more.
You want to do one more? All right, that means you have to do it though. So this guy's 58. He fell 16 months ago. Now has myelopathy.
There's a lot of cord signal abnormality.
Yeah, there's a lot of cord signal abnormality. So this is T2, like the cord is expanded, like it doesn't look so hot. This is post-contrast, I think. Any like real enhancement there, you think? Maybe not.
If I had T1, but yeah.
I'll give you some more images.
Yeah.
So here's like a little lower. This is T2 and post-contrast again. There's like at the level of the conus.
Yeah, I mean, it looks a little expansive.
Looks like pretty terrible, right? Like, and there actually is like pretty avid enhancement there. All right, so here's like just some axials through that same region. So you got this long segment like lesion in the spinal cord that's kind of enhancing. Like, what do you think? Give me.
Could be. I mean, I would be concerned for possible mass, like central canal obstruction higher up, but it wouldn't be enhancing. And then demyelinating active, but that would be weird too.
Yeah, so I think like some sort of inflammatory or infectious myelitis, like something active going on. I think some sort of tumor. I mean, I think you're like on track there. There's no way in hell that like some sort of obstruction higher like caused it to look like this, unless you infarcted the cord. And a cord infarction can look like this. Lymphoma, like some crazy things can look like this. All right, well, I'll give you some more information now. But then you got to tell me what kind of study this is.
So conventional angio.
Of what?
I'm guessing this is the artery of Adamowitz.
Exactly. So this is a spinal angiogram.
And then you have the hairpin.
Yeah, exactly. So this is a spinal angiogram, and a spinal angiogram, you take a catheter and you like drop it in every level spinal artery. So there's bilateral spinal arteries at every level in the thoracic and lumbar spine, and you do it in every level until you find the artery of Adamowitz, which is this artery here. And in this case, like you're looking for something else because vascular lesions were a consideration here. That's the artery of Adamowitz. Here's like a different spinal artery. This is like T8 on the right. You don't have to tell me more about this. You like walked into this too voluntarily. This is a spinal artery. 1, it should not be this big. 2, you should not have like all these connections. 3, you should not have all these like draining veins. Okay, this is what a dural AV fistula in the spine looks like. This is a disease of like men in their late 50s and early 60s. They tend to get these vascular malformations. They have progressive myelopathy, and it goes undiagnosed for a very long time. If you follow this angio out, you actually see veins filling all the way up like into his cervical spine. I will make you answer this question though, since you.
Okay. B.
It is a treatable cause of paraplegia, and so that's actually very important. Like, so the average delay to diagnosis is almost a year for these patients. It gets progressively worse, and the symptoms become progressively more irreversible. So you need to like be at least suggest that when you have these long segment myelitis, that's like sort of in the thoracolumbar spine, you got this long segment cord edema, and then you kind of have the suggestion of these tortuous vessels. And it's like kind of small here. It's sort of difficult to tell. When you're at the PAC station, it's a little easier. But but yeah, you should be looking for that. And you can have variable enhancement. Here's your fistula. They put in a catheter. They put some glue in there. They close it off. The patient is cured. Okay. They may not get their walking back, but they will not progress further. So whatever level of like walking that he have, like they won't get any worse. All right. So why don't we stop here? Just in summary, like, you know, think about spine like it's the CNS. It's not that bad. All these things like have terminology. If worst comes to worst, just write it down phonetically and like search it, type it into Google later. It will figure it out. Any questions or anything? You guys have a Merry Friday and a happy holiday.